All right, I'm going to go ahead and get started. Just as a reminder, we are recording this and we're also live streaming this on the Department of Education's Facebook page. I want to thank all of you that have joined us as participants, as panelists, for taking some time out of your busy day to join after work hours and listen to information from our experts. I'm Ryan Brown. I'm the Chief Communications Officer at the South Carolina Department of Education. And our agency's role in public health and in public education is to keep students in school happy, healthy, and learning. And we're very thankful for our partnership with pediatricians and doctors across our state that have aided us pre-pandemic and during the pandemic, and certainly our partnership with DHEC, which has been in place for many, many years. So this evening, you're going to hear from two doctors, Dr. Martha Edwards, who's a pediatrician, and Dr. Jane Kelly, who's an epidemiologist at DHEC. And you'll also hear from myself and from Tom Hudson, who is over the South Carolina School Improvement Council and is also the co-director of the Carolina Family Engagement Center at the University of South Carolina. We will have an opportunity not only to hear from these experts, but also to ask questions. On your screen, you'll see a chat function on the right-hand side. You should also see a Q&A function on the right-hand side. You can ask questions through either one. The Q&A function will only be seen by our panelists and myself, whereas the chat function can be seen, depending on who you send it to, by all attendees. So we'll take questions either way, and then we will also, for those joining us via social media, we'll take your questions as well, so you can leave those in the comment section on Facebook if you're joining us that way. We're excited about this. We appreciate the panelists who have joined us, and they're willing to share information. Our role is to make sure that factual information is out there so that people can make informed decisions. And certainly when it comes to the health and safety of our youngest learners, our children and our students, that becomes even more imperative. So we appreciate our two doctors that have joined us this evening. Before we introduce them, I'm going to turn it over to Tom Hudson, from the South Carolina School Improvement Council and co-director of the Carolina Family Engagement Center. So Tom, please take it away.
Thank you, Ryan. I'm pleased to be here on behalf of both the South Carolina School Improvement Council and the Carolina Family Engagement Center for this evening's virtual town hall on the pediatric COVID-19 vaccine. These past 2 years have no doubt been the most challenging in our lifetimes for educators, for students, and for families. I can't tell you how many times these last months that I've had a principal or a district administrator or a parent tell me how helpful and indeed vital their school improvement councils have been during this time of pandemic in helping them bridge what could have been a real communication gap between their schools and their greater school communities. Whether it's with our state's 1,100 plus school improvement councils, their 13,000 local SIC members, and the variety of work they undertake each year to strengthen their schools, or with the Carolina Family Engagement Center's work in building a strong infrastructure supporting family engagement with more than 24 schools across multiple districts and a stable of active community partners. The sharing of information is not just important, it's essential. Our parents and families rely on this if they themselves are to make informed decisions for their children. You see, the thoughtful and trusting relationships are truly the foundation of all effective family-school community partnerships. Decades of research shows us that strong family and community engagement in our schools supports a whole host of positive outcomes, such as increased student achievement, improved behavior, better attendance, and higher graduation rates. But it's not just these. Effective family-school community partnerships are key because not one of us is in this alone, that our children and their futures depend on us all. South Carolina School Improvement Council and the Carolina Family Engagement Center appreciate the commitment of the South Carolina Department of Education, the South Carolina Department of Health and Environmental Control, and the South Carolina chapter of the American Academy of Pediatrics for making this particular effort to provide information for families, to answer their questions about the pediatric COVID-19 vaccine. I look forward to learning a lot myself this evening, Ryan, so thank you for hosting us.
Thank you, Tom. I appreciate you being with us and your leadership and the leadership of parents across the state who serve their school communities on school improvement councils. They play a major role, and we appreciate you all being a part of this. As I mentioned, for those of you just joining, I mentioned earlier, you can ask questions via either the chat or the Q&A function on WebEx. Either of those will allow us to pull those questions. We're going to address them at the end of these presentations. So we'll hear first from Dr. Edwards and then from Dr. Kelly, and then we'll take those questions from the audience. But please feel free as they present, and you may have questions to submit them via the chat or Q&A function. So our first presenter is Dr. Martha Edwards. Dr. Edwards is a pediatrician in the Rock Hill area of the state, and she also serves on the executive committee of the South Carolina chapter of the American Academy of Pediatrics. Dr. Edwards and the American Academy of Pediatrics, the South Carolina chapter, have been great partners for us, particularly as it relates to student health during the pandemic, and we're very appreciative that she's taken some time after her work hours of seeing patients all day and coming to speak with us. So Dr. Edwards, I'm going to turn it over to you. I know you've got some slides you want to show, so if you want to cue those up, we're ready to hear from you.
Okay, thank you for having me, Ryan. Appreciate it. Let me see if I can cue these slides. And so, as Brian said, I am Dr. Martha Edwards. I'm a pediatrician in Rock Hill, and I'm currently serving on the executive board of the South Carolina chapter of the American Academy of Pediatrics. I practice general pediatrics, and I've been in practice nearly 30 years. I'm also a mom, and so for those of you parents out there, I mean, I think I understand what it is to worry. That's what we do so well as moms. Sometimes it's worthwhile and sometimes it's not. And but I think these are big decisions we're having to make, you know, all the time in these last couple of years, especially for the safety of our children. And I understand why people are sometimes hesitant, want to get more information, and I'm really appreciative that all of you have tuned in this evening. So the question I'm here to answer, you know, as Ryan said, I did spend most of my day today at work seeing patients, and you know, I had this conversation with a lot of people. Why vaccinate your child ages 5 to 18? Vaccines are now available for those ages. And so I kind of, you know, when I think about it, I think of really 3 to 4 things. Children can get sick, and so we want to protect our children. We want to protect our family members. We want to protect our community. And then we also, as Ryan was saying, we want to keep our children in school. So I was going to go into kind of each one of those things and why the vaccine might be something you really want to think about in order to do all of those things for your child. So first of all, you know, I think there is the numbers of children who are getting sick right now with COVID. When I last heard, 27% of the new cases are in children right now. A lot of the time, honestly, they don't get very sick. Most children don't get extremely ill with COVID. The mortality rate, thank God, is very low in children. However, we have had about 700 children across the United States actually die of COVID. And then we have had, especially with the Delta variant, a lot more children having major illness with the acute illness, as well as about a month later getting sick with something called multi-system inflammatory syndrome in children, which is just kind of a whole body inflammatory chaos, basically, that really affects, you know, the heart, the lungs, the brain, the kidneys, the liver. And it's a really tough thing to get through. 46 children have died of that. But the ones that don't die, it's still a really rough way to go. And I brought up this slide, I wanted to, this I pulled from the beginning of September. So as school was starting and we were starting to see a lot more cases of Delta virus in kids, the South Carolina Children's Hospital Association Collaborative pulled together numbers from all of the children's units across the state of South Carolina, looking at who was in our ICUs, how many children were in the hospital with COVID, how many children were in the ICU with COVID, how many children were on ventilators, how many were vaccinated, and how many were unvaccinated. And so first of all, one thing you might notice that the dots, if you kind of look at the key, and I think it's hard to see it, but all of the dots, these are all unvaccinated children. The yellow dots are children under 12 who at that point didn't have the chance to be vaccinated. The purple dots are children over 12 who did have the opportunity to be vaccinated, but we did not see any children in the ICUs who had the opportunity, who were 12 and up and were vaccinated. And so my friends who work in the ICUs, who are in the emergency rooms, you can imagine the frustration of, after a while when we start to really see this, where we're seeing unvaccinated child after unvaccinated child who's getting very, very sick. And we're sitting with parents who kind of have this realization, I could have vaccinated my child and perhaps avoided all this. And so when I think about children and COVID, again, most of the time things go very well. But today I had a child who, had fallen off a bike, had fallen off a dirt bike, flipped over his handlebar, had a helmet on. He was okay because of that helmet. I think of the vaccine sort of like that. Sometimes the vaccine may not completely protect you against getting COVID virus, but it certainly does decrease your potential of having to be hospitalized or being in an ICU. And that's the same for adults as well. And so that is the frustration I think that we in the medical community are seeing, for anesthesiologists who have to intubate their patients, for ICU doctors and nurses, for emergency room physicians, that a lot of this illness could be avoidable. So next slide. The other reason is protecting your community. We want to make sure that our hospitals can stay open for, if your mom has a heart attack, or if your dad has a stroke, or, God forbid, if your child has cancer and needs treatment for that. We want to make sure that everybody has access, that our emergency rooms are not flooded, that they can function as efficiently as they possibly can. And when our rescue squads and our hospital ERs are flooded with patients, it's really hard to have an efficient hospital system, an efficient healthcare system. This is, from hospitals in our area, which we had been right across the border, but to North Carolina and to the Atrium system. But Atrium and Cone Health and Novant Health got together and pulled numbers. This is a graphic again from early September, and there were a bunch of these coming out. But if you look on the left side of the graphic, there were 754 people hospitalized. 91% of those were unvaccinated. And that time, well over 50% of the people in our area were vaccinated. And so if the vaccine weren't working, we would have expected that about half the people in the hospital should be vaccinated, but that's not what we're seeing. And as far as ventilation and being on life support, when we looked at the people on life support, 95% of the people on life support were unvaccinated. And that's something that we've seen consistently. The people that need a lot more support, that need ICU care, they may get through this and survive, but they often have long-term sequelae. They have inflammation all over the body. They have damage of blood vessels and kidneys and liver, lungs. They are on oxygen long-term. And that's another thing with children. At least 2%, I've read anywhere from 2 to 7% of children have long hauler syndrome, which is prolonged symptoms associated with COVID, and they can be weird. Often, you seem to have a very benign course, but then children, sometimes I've heard of an 8-year-old having to get a pacemaker, children having a lot of dizziness and runs of very fast heart rates after having COVID virus. And we see the same thing in adults. So vaccines do seem to prevent those things quite effectively. Family members can get sick with COVID, and that's another reason to get children vaccinated. Children who get COVID from school, they can spread it to family members, they can spread it to at-risk teachers or friends. And it is much more likely to be spread in folks who are unvaccinated, especially to folks who are unvaccinated, than in vaccinated populations. I hear a lot, people are very concerned about boosters. Why are we going to have to keep getting boosters? We don't know yet. This is new to all of us, but it's not at all surprising to us that do a lot of vaccines and have been watching vaccines and obsessed with vaccines for most of our adult lives, that we do need boosters. Our immune systems need reminders. Our children often get 3, 4, 5 of the same vaccine in their first several years of life, because we want to make sure that they don't get whooping cough, that they don't get diphtheria, that they don't get polio. And most of the vaccines we give take at least 2 doses to be effective. And so we want to protect family members with the vaccine. And the more people that get vaccinated, the better we're going to do. Vaccine decreases the viral load, the duration of illness, and the possibility of transmission in those who get it. We know that, as of about a month ago, 140,000 children had lost a parent or caregiver due to COVID. And that's another reason to get children vaccinated, is to protect those that love them, that care about them, and to make sure that those children can still be cared for by the people that love them the most. This is a screenshot I took. Again, this is from early September, and we may have another surge this winter, we'll see. But in early September, we were seeing a lot of COVID as children started to go back to school. Our district had no mask requirement. We did encourage masking. I was disappointed in that, because I think that's another layer of help that we can give to help prevent severe illness. But children who are vaccinated can stay in school more consistently. This may be changing, I'm not sure, and Jane can maybe fill us in on that, but the CDC at that time was not recommending quarantine for asymptomatic students who had close contact with someone with COVID. They did not need to quarantine unless they got symptoms, if they had the vaccine. And when we look at, this is the dashboard, the D stands for dashboard on the side of this little screenshot. We had, 1,500, sometimes I think we were up to 2,000 of our students quarantined at one point. And this was a huge interruption for school. So the more folks we can get vaccinated, the better we're going to do. People ask, what if there are long-term side effects of the vaccine? It hasn't been out that long. Should we, what's going to happen in 30, 40 years? And what we can say from long experiences with many different types of vaccines is that we've really never seen a vaccine cause long-term side effects, and we've not seen side effects happening after about 6 weeks after the vaccine. So we do feel confident with these vaccines as well. On the other hand, we know that COVID does cause long-term side effects, if you want to look at it that way. It causes long-term sequelae. And we have a lot of examples of other viruses that do that as well. If you think about chickenpox, you may know of grandparents or parents that have had shingles, which is a very painful skin condition that can happen 30, 40 years after you've had wild type chickenpox. We know that hepatitis B can go on to cause liver cancer. We know that human papillomavirus vaccine, HPV, can cause cancer 30, 40 years later. Polio certainly causes long-term problems, paralysis. Mumps can cause infertility. I could go on. Measles weakens the immune system for many years after the infection. So my point here is that when we give vaccines, we're not giving them for minor things like colds that most people get over pretty well. We give them for serious viruses and bacterial illnesses that can cause severe illness or death, and we want to avoid that. So when we're looking at this equation, what's safer, the vaccine or the virus, there's really no question. And if you talk to doctors that have actually been seeing patients with this, intubating patients, sitting with them, holding their hand as they're having to say goodbye to loved ones, most doctors feel very, very strongly that vaccines are the way to go. So a lot of people, we've heard this. This is something that's been brought up with multiple different vaccines from folks who provide often disinformation or misinformation about vaccines. Is there a chance of infertility if your son or daughter takes the vaccine? And actually, no. The vaccine seems to protect against that, or at least be equal. Even in the early studies, when they were trying not to vaccinate pregnant women, we saw people get pregnant. There were about half in the group that was being studied that got the vaccine that got pregnant, half that did not get the vaccine that got pregnant. So the evidence now, after giving billions of doses of the vaccine across the world, is that it is so much safer to have the vaccine when you're a pregnant woman, and that you're so much likely to have damage, to have a miscarriage or to have preterm delivery, that the American College of Obstetrics and Gynecology very strongly recommends that pregnant women and or women considering becoming pregnant get the COVID-19 vaccine, since it decreases the risk of bad outcomes from COVID. And also breastfeeding women should get the COVID vaccine. So that's a strong recommendation now. The other thing that a lot of people have asked me about, and my husband is a heart doctor, and so we talk shop a lot. But one thing that it caught everyone's attention early on is myocarditis. And the first place that it caught everyone's attention was that we were seeing a lot of cases with myocarditis in people that had COVID virus. So not the vaccine, but the virus. And so that is actually much more common than seeing inflammation of the heart, which is myocarditis, in people that have had the vaccine. So it is a side effect of the vaccine that you could possibly get myocarditis or inflammation of the heart in the 16 to 30-year-old age group, and in men more commonly than women. However, that is so much less likely than to have that complication with people who have the COVID virus, that it's recommended to get the vaccine. I have a 25-year-old son who actually has a heart condition called hypertrophic cardiomyopathy. And, I wanted that he was the first person I thought of. I really wanted to make sure that he got the vaccine to protect him against any cardiac complications. It's much, much less likely that he's going to have problems after getting the vaccine, should he get COVID or should he come in contact with COVID. So that's my last slide. The only other thing I want to say is when I think about, again, after practicing for 30 years, I'm old enough to remember when we had no vaccines against bacterial meningitis in toddlers and infants. And we saw that quite commonly when I was in residency. We would do spinal taps a lot in the emergency room. And when they came out with the H-flu vaccine and the Prevnar vaccines, at first, we really, we still saw some cases of H-flu meningitis or pneumococcal meningitis. And we were like, what's going on? We have vaccines. Why are these kids still coming in sick? And my attendings at the time, my mentor said, let's give it a while. And, really in the last 25 years, I haven't seen one case of any of those, of either one of those conditions. And that's because everybody got vaccinated. And so what we know is that if we can really get more and more people vaccinated, we're going to have better outcomes. So I'm going to leave it at that, and I'm happy to answer questions later. I wanted to pass the baton on to Dr. Jane Kelly. Dr. Kelly is the Assistant State Epidemiologist. Let me stop sharing. There we go. The Assistant State Epidemiologist for South Carolina, and it's my understanding that she actually came out of retirement to do this. She has a huge fan club, including doctors, nurses, school people, insurance people, as somebody said the other day in a meeting, But anyway, Dr. Kelly is going to talk a little bit more about COVID vaccine and COVID virus. Thank you.
Thank you for that kind introduction. And yes, it is true. I had been working for CDC, retired, moved to lovely South Carolina, and then decided when COVID came, I could not just sit back and watch what was happening without trying to help. This is what's called the epidemiological curve, the EPI curve of new cases in South Carolina, and it looks like quite the roller coaster. The blue bars are the number of new cases on a single day. The green line is a 7-day average. And as you can see, after that huge surge that we had in August and September, fortunately, numbers have been coming down, down, down around number of new cases. But I want to point out two things. Number one, we're still not as low as we were back in June of 2021. And number two, where I've got that red arrow, that lowering, the decreases in new cases is starting to plateau. And we do have serious concern that it will increase again with the holidays as people travel, visit with non-household friends and family, that we may see an increase. And so they're still feeling some urgency about vaccination. I looked on our data, around new cases by age, and looking from August, 3 months, August through November, and found that fully a third of new cases were in children and adolescents under age 20. And for the 10 and under, and for South Carolina, it's about 14% of new cases. So it is disproportionate to the number of people in that age group. So I'm going to cover some of the same things that Dr. Edwards covered, but I want to give you a little bit more in terms of what are the numbers? What is the data? Why are we even talking about vaccine for ages 5 through 11? Almost 2 million 5 through 11-year-olds in the United States have been infected with COVID-19. There was a sharp increase, just as I just was showing you, in cases during the time when the Delta variant became predominant. Right now, the Delta variant is more than 99% of new cases in South Carolina. And the reason that is important is twofold. Number one, the Delta variant spreads more easily. And number two, the vaccine covers the Delta variant. There have been more than 8,300 COVID-19 hospitalizations through 5 through 11-year-olds. You don't hospitalize a child in that age group unless they need oxygen or they're substantially ill. More than 30% of those children hospitalized in that age group did not have an underlying condition. So when people say, my child's, is strong and healthy, doesn't have any chronic medical conditions, so I'm not worried. This is a very puzzling disease. It is unpredictable. There have certainly been children who have no chronic underlying condition who have ended up in the intensive care unit. In fact, a third of these kids in this age group nationwide who were hospitalized ended up in the intensive care unit. There have been 94 deaths nationwide from COVID among 5 through 11-year-olds. And lest that sound like a small number, I'd like to point out that COVID-19 was the 8th leading cause of death in this age group, and it went up to being the 6th leading cause of death in that age group with Delta. There's some concern that the Delta variant causes more severe disease. I've borrowed a couple of slides from Dr. Allison Eckert from the Medical University of South Carolina in Charleston, and it's similar in a number of ways to what Dr. Edwards has already shown. But I wanted to make the point, again, that what they were seeing in MUSC is that 0% of the children who are being admitted for pediatric COVID-19 related admissions were fully vaccinated. But the scary thing is looking at those red bars, how the numbers really jumped up. That's when the Delta variant arrived in South Carolina. And Dr. Edwards has already mentioned the multi-system inflammatory syndrome in children, relatively rare, but that's a relative term. Across the entire country, there have been over 5,000 cases of this among children and adolescents, and that there were 46 deaths from this condition. Here, specifically in South Carolina, what were we seeing at MUSC? Again, I'd point your attention to that red bar, that kids in that 5 to 12-year-old age group seem to be at increased risk of MIS-C, the multi-inflammatory syndrome. They were accounting for more than half of the cases that were being hospitalized at MUSC with this condition. But it's not all about severe illness, and it's not all about death. It's also about this condition called, nicknamed long COVID. About 10% of kids, it's estimated, experience long COVID with symptoms that last for more than 4 weeks. Even children who had really mild or perhaps even asymptomatic infection at first sometimes develop symptoms later. And they're very debilitating symptoms: fatigue, headache, can't sleep, trouble concentrating, muscle and joint pain, cough. You can imagine how that impacts their quality of life, how that affects their mental health, how that affects their performance in school. I also want to point out that while we have a lot of prevention or treatment options in adults, we do not for ages 5 through 11. For example, you may have read about 2 pills that have applied for an emergency use authorization: Molnupiravir, Paxlovid. These are pills that you can take if you get COVID-19 that are powerful in preventing your progressing to severe disease and needing to be in the hospital. They're not going to be available for ages 5 through 11. Right now, we do have monoclonal antibodies. These are passive antibodies that are made in a laboratory and given to someone who's infected with COVID-19 to help prevent them from severe disease and hospitalization, except you have to be 12 or older to receive them. The only prevention option we have right now, sorry, that's a typo, I should say Pfizer vaccine. And this new Pfizer vaccine has shown it is 91% efficacious in preventing hospitalization in ages 5 through 11. And I would be remiss not to mention the one other thing. As you know, as parents, if your child is a close contact to another person with COVID-19, our current recommendation, they're a close contact, even if they have no symptoms, if they're not vaccinated and they don't have a recent COVID infection, we ask them to quarantine. If they're fully vaccinated and have no symptoms after being a close contact, they do not need to quarantine. The reason for that is what I call breakthrough infections. Infections in people who are fully vaccinated are rare. They're less than 1% of the cases that we're seeing nationwide and in South Carolina. So if your child is fully vaccinated and they have an exposure, they can stay in school. All right, what are the symptoms that are associated with this vaccine? You know, everybody's worried about, well, what will my child experience? This is from the study that was done, the phase 3 study among the children who received the Pfizer vaccine. They found that a good number of them did have pain at the injection site. That's the green and blue bars where it says pain at injection site. But I'd like to point out the BNT162b2, that's the medication, that's the vaccine. Right next to it, 31% of kids who got the placebo complained about pain at the injection site. And green means mild. The blue is moderate. These are symptoms that last for 1 to 3 days. Redness, soreness, swelling also occurred after both the first dose and the second dose, but at about a comparable rate. What about full body symptoms, systemic symptoms? Well, the main ones, and this is very similar to what we see in adolescents and in adults: fatigue and headache. But I'd point out that it's fewer than 40% of these children in the study were experiencing fatigue or headache, and the other symptoms at a much lower rate. This is a lower rate of systemic symptoms compared to adolescents. And that makes sense to me because the pediatric dose is 10 micrograms. The one we use in adolescents and adults, age 12 and older, is 30 micrograms. So they're getting 1/3 the dose and they have fewer symptoms. For all of us, in any decision we make, whether for ourselves, our family, our children, we have to weigh the benefits and the risks. 91% efficacy is very close to what it is for adults and adolescents. So the benefit is that these vaccines are highly effective in preventing severe disease. The risk that most people talk about is myocarditis, which has already been mentioned, but I want to go into a little bit more detail. Myocarditis is the medical term for an inflammation of the heart muscle. Its risk varies with gender or sex and age. And right from the start, I want to point out we have had over 220 million doses of the Pfizer vaccine given in this country alone, and there have been 0 deaths from vaccine-associated myocarditis with the Pfizer vaccine. The risk of myocarditis is higher with disease than with vaccination. And for those of you who want to read the evidence for yourself, I think that I provide a link so that you can look at this study that found that the risk of myocarditis, 16 higher risk of myocarditis among people who have COVID-19. And this is of all age groups. But let's go back to talking specifically about myocarditis in younger groups. What do you find if you Google myocarditis? You find out that myocarditis is associated with all sorts of different things, with autoimmune conditions like lupus. It's also associated with certain medications. There are some genetic predispositions. It's associated with hepatitis. However, what you'll read associated with a number of those conditions is that it can be very serious. What we are seeing is that the myocarditis associated with vaccine is, number one, rare, but that it's not like myocarditis associated with those other conditions. It is mild and it resolves literally within days. Now, this table is to look at who has the highest risk for myocarditis after vaccination. And the group with the highest risk is boys age 16 to 17, and it is thought to be related to hormones. They have a risk of about 70 cases per 1 million doses of vaccine given as the second dose. You'll notice that it's lower for all the other age groups. As you get younger, as you get older, that risk is lower, and it's thought, as I said, to be related to hormones. Now, what do we know about ages 5 through 11 and myocarditis? Well, there were 0 cases of myocarditis in the phase 3 study, but it was, you'd have to give millions of doses before you would really know what the number of myocarditis cases. So let's look at what we know about myocarditis in general. No cases in the study, but that's what we expected. It's a rare event. Probably there will be a lower rate of vaccine-associated myocarditis in the 5 through 11 group. Why do I say that? Because myocarditis from other causes, for example, certain viral illnesses, is lower among children aged 5 to 11 compared to those under 5 have a higher rate and over 12 have a higher rate. And as I just mentioned, the dose in the pediatric Pfizer vaccine is 1/3 that which is given to adolescents. But let's just do a mind experiment. What if we assumed that the rate of vaccine-associated myocarditis for 5 through 11 was the same as ages 12 through 15? What would that mean? I have trouble when we start to think in terms of 1 million doses, and I'm a visual person. So here's my visual analogy. Visualize a football stadium with 80,000 people in it. Now imagine this is 80,000 boys ages 5 through 11 who all got vaccinated. 3 of them, on average, would experience myocarditis. It'd be mild and it would resolve completely. The number for girls is even smaller. Girls ages 5 through 11, all vaccinated, less than 1 would experience myocarditis. And just to compare hospitalization for COVID and hospitalization for myocarditis, they're very different animals. Hospitalization and intensive care unit for COVID is because you have severe disease, you need to be on a ventilator, you might need some other interventions like dialysis. It's often a long hospital stay with a long recovery time. A child who has vaccine-associated myocarditis, we do routinely hospitalize them. We often put them in the intensive care unit for cardiac monitoring to make sure that they don't have an arrhythmia. It's not invasive. It's usually less than 5 days. And I just want to give you one study that looked specifically at hospitalization for myocarditis. Because again, if you Google myocarditis, you'll read a lot of scary things, but you may be reading about classic myocarditis. So this was a study at Emory University. They looked at the medical records of people of adolescents and children that they had hospitalized for classic viral myocarditis, that multi-inflammatory syndrome myocarditis, and COVID-19 vaccine-related myocarditis. This is a little bit busy. I would draw your attention all the way to the right with those green bars that say 100%. These are all the cases of vaccine-related myocarditis at Emory, at discharge, and then at the 3-month follow-up. 100% of them had normal heart muscle function. 100% of them were not on any heart failure medications. If you look all the way to the left at classic myocarditis, this is where you'll read scary stories. Those kids, about half of them were not on heart failure medications, but a good 44-45% of them had to be on medication, and a small number of them had really severe disease that needed intervention. The vaccine, my point here is vaccine-related myocarditis is not the same thing as what you might read about in general. So, all right, if you want to get your child vaccinated or you want more information, what can you do? You can go to our DHEC Vax Locator website. You can type in your zip code, or you can click on where it says View Map or Filter by my current location, and it will bring you to something that looks like this. It'll bring you a list of all the vaccine providers in your area that have vaccines. And the pediatric vaccine is specifically labeled Pfizer Peds, PZRP. Because some locations, like Coastal Pediatrics, they're only vaccinating children. Whereas some others, they might have the regular adult Pfizer and the Peds Pfizer and some other vaccines. But you can look at those, you can contact those providers to make an appointment. Right now in South Carolina, we've had more than 19,400 children aged 5 through 11 years who have had their first dose of vaccine in South Carolina. And I've seen a lot of people posting, real positive images on social media. I've also seen images of kids who look anxious about getting vaccinated. And I just want to say a couple of words about what you can do if you're preparing your child to get vaccinated. How can you help with their anxiety? Number one, tell them what's going to happen. This is really no different than any other vaccine that they've ever received. You see in the lower right-hand corner, there's a child that's brought a stuffed animal. Things like that can really help. I know a number of people advocate for, afterwards, reward them. Take them out for a donut, congratulate them for being brave. I do want to cover a couple of FAQs. The formulation for the PEDS vaccine is different from the adult vaccine. So is the child vaccine the same as the adult? Nope. Different formulation, smaller dose, smaller amount of liquid injected, and a smaller needle. Comes in an orange cap, orange label, so it really stands out to the providers. Can your child get COVID-19 from the vaccine? No, it's impossible. There is no whole virus in the vaccine, just the gene for what's called the spike protein. The spike protein is what attaches the virus to the human cell. It is the active ingredient in this vaccine. It's called messenger RNA because it carries the message for how to make the spike protein. Everything else in the vaccine is very simple. Salts, sugars, some lipids or oils to coat that gene so muscle enzymes don't destroy it before it does its job. And something called polyethylene glycol. This is a common ingredient in over-the-counter laxatives such as Colace. It does cause rare allergic reactions in adults and adolescents. We've seen about 3 to 5 allergic reactions per million doses of vaccine. That is about the same as what we see with influenza. That is much lower, for example, than what we see with penicillin. This vaccine has no antibiotics, no egg, pork, preservatives, adjuvant, latex, mercury, or aluminum. A couple other FAQs, and then we can take some questions live. What about my child is 11, but big for her age? Can she get the Pfizer 30 microgram dose? No, vaccine dosing, this is not like antibiotics. It's based on the age and the maturity of the immune system, not weight. Well, how about my child is 11, but if I wait a month, he'll be 12 and I could get him a bigger dose. Should I do that? No, you don't want to risk that he might get COVID in the interim. We are still at moderate to substantial community transmission in South Carolina. What if you get the 10 micrograms at age 11, the PEDS dose, and then you turn 12 at the time of your second dose? What do you get? You get the age appropriate dose. You get 10 micrograms at age 11, 30 micrograms at age 12. There is a lot of information available on the CDC website. This one happens to be a web page for pediatricians, but I think it has so much information that, and I think it's very readable, so that people can read on their own about what to understand. Might have a lot of the questions, the answers to a lot of your questions on that page. And as long as you're getting your COVID vaccine, don't forget to get your flu shot. I'm going to end there. I'm going to leave my, I'll put it in the chat box too, I suppose, that you're welcome to email me directly if you don't get your questions answered tonight. My email address is kellyjm1@dhec.sc.gov. Thank you. I think I'm no longer sharing.
Thank you, Dr. Kelly. You've clearly gotten a lot of these questions before, because in your FAQ, you covered about half the questions that we've received thus far. So very clear that many parents have similar questions. Just as a reminder for those that are watching online or have joined us here, you can put your questions in the chat function or the Q&A function. We've gotten quite a few so far. So Dr. Kelly and Dr. Edwards, we're going to let you kind of tag team these, and I'll let you decide amongst each other who's the best person to answer. First question we have is, can the COVID-19 vaccine cause variants or make you test positive on a COVID-19 test?
No, it definitely will not. The vaccine will not cause you to test positive. If you get vaccinated and then later on have a positive test, then you are one of the rare breakthrough cases. That means somebody who's fully vaccinated, but gets exposed to the virus, picks it up, and has a positive test. The vaccine will not turn your test positive. It is true that some people get these breakthrough cases. The good news is the vaccine will help prevent you from progressing to have more serious disease. You'll have a milder condition if you get infected.
Okay. My child already had COVID-19. Will it be necessary for them to get vaccinated?
I would say yes, it is a good idea. I actually tried to answer this and it wouldn't send, but I do think it's a good idea. You get with the vaccine a much more reliable and durable immunity. You get better antibody response, and then you also get more stimulation of the other parts of the immune system that are important in mounting a good, healthy immune response. We get variable, sometimes different levels of immunity if somebody has a mild infection or a severe infection. Generally it looks like antibodies last a while with wild type infection, and then sometimes fade, sometimes last okay. But what we're seeing is we have a more reliable, durable immunity with the vaccine. Let Jane comment if she has anything.
I will add to that. We know that in adolescents and adults who had prior COVID and then get vaccinated, they cut their risk of reinfection in half. We know that from studies in the United States and studies in Israel, where they have vaccinated millions of people.
Thank you both. This is not a 5 to 11 question, but an adolescent question. Should adolescents who are aged 12 to 17 who are immunocompromised get an additional dose of COVID-19 vaccine after receiving the primary series?
I would say, I always defer to talk to your doctor who knows you the best. But most likely it is a good idea in order to increase your immune response. I don't think there's a formal recommendation for teens yet on the booster. And Dr. Kelly can correct me if I'm wrong, but I think it's always a good idea to talk to your personal physician about that.
I can give you a little bit more information, the recommendation on the booster. If we're talking about a booster 6 months after the primary series, there is not a recommendation for people under age 18. So the regular booster 6 months after your primary series is just for 18 and above. However, If you are immunocompromised, the recommendation certainly is to consult with your physician, but the general recommendation is if you are immunocompromised, and that would be people, for example, cancer, receiving chemotherapy or radiation, or someone who's got a organ transplant or autoimmune disease where they're on a medication that suppresses the immune system. It is recommended they get a third dose, and they don't need to wait for that 6-month point. They just need to wait 28 days after their second dose of vaccine, and that is available for ages 12 and up if they're immunocompromised. Ryan, it looks like you're talking, but I think you're muted.
Yeah.
Technology. Similar question is if we anticipate the younger children, 5 to 11, needing a booster further down the road, or if we have any response to that.
I'm going to say I think we don't know yet. I think it's probable based on other vaccines and the history of the vaccines that we've seen. One reason that the vaccines were initially spaced so close together is because this is an emergency. We've seen, 700,000 people in our country die of COVID or COVID-related symptoms, and we wanted to get people vaccinated and protected as quickly as possible. And so it does look like we may need to spread out, that third dose or get an additional dose. Certainly, we've seen that with older folks. Kids are different, though. They have great immune systems, and sometimes I think we'll only know with time.
I have a question about earlier, you both talked about children in ICUs, and there was a question that came in that if there was any correlation between those and any comorbidities that you all think may be contributing to them having to be in the ICU.
That's a great question. And what I would say that I'm hearing is that a lot of times, no. I mean, there are people that are healthy, but also when you think about comorbidities, sometimes we've seen special needs kids or asthma. Obesity is a big one, and that is up to 50% of our youth in the state. And so it's not uncommon to have comorbidities, but also, when I think about these special needs kids that sometimes are getting very sick, they weren't getting sick before COVID, and we can definitely protect them by vaccinating ourselves and by vaccinating those around them as well as we can, and additionally getting them vaccinated if they can.
Question about immunization records and if the COVID vaccine will be stored in a child's immunization record.
Yes, I think, most of us are, even if they're vaccinated outside of our practices, it gets faxed to us and we try to put it into the vaccine registry for South Carolina. I think it's important to track it if you can keep track of that vaccine card yourself, because I think that's variable with a lot of different places doing this. But, the more you can track that, I think ultimately it will be in the child's vaccine record.
We had a question that came up, Dr. Kelly, when you were talking about what the mRNA vaccine is, and if you could explain in layman terms what the difference between the mRNA is and vaccines that are made with, with a live virus.
Sure. So the traditional way of making a vaccine that's been used for many, many different vaccines is to take a bacteria or a virus and either weaken it or inactivate it so that you can't get the disease from it. The tricky part about that, though, is there's always that lingering concern that if it wasn't adequately inactivated, or if it were just a weakened virus, but it turns out this person had an unrecognized immunocompromised condition, that they might actually get the disease. So it would be nice to find a technology where you could move away from using an inactivated, weakened, or attenuated virus. This technology with this mRNA, this may be news to most people in the United States, but there have been other vaccines made by this technology. So the idea here is, instead of taking the entire virus, let's just take one little snippet, one little piece, and not even a piece of the virus. Let's just take a piece of the virus that is the genetic code, the gene for a particular protein. Which protein to pick? Well, do you remember SARS, the original severe acute respiratory syndrome back in 2002, 2003? There were about 8,000 cases and 800 deaths. It was a pandemic. We had cases in the United States as well. It's very closely related genetically to SARS-CoV-2. So the research on this vaccine actually started back in 2003. And that's why so many of the studies were looking at what would be the best target. If we were going to make a vaccine against this virus, what would be the best target? And it's really telling that most vaccines around the world are using the spike protein as their target, because it's the spike protein that gets the virus into the cell. And again, you may not have heard of an mRNA vaccine, but it's been used, this technology, this approach is sometimes used in what's called cancer immunotherapy, because your immune system also fights off cancers. So the whole idea is to make a vaccine that will be safer, that doesn't need to be grown on cells or on eggs, where you have to be worried that somebody might be allergic to an egg protein. And it's also nice because if we do get new variants for which our current vaccines are not adequate, they can tweak that formula, that gene, to match the new variant. Right now, all three of the vaccines that are available in the United States are highly effective against the Delta variant. I hope that answers your question.
I was going to say something too with the mRNA. It actually, its shelf life is very short inside the body. And so it gets into the cell, it does its job, it makes proteins. The proteins are then recognized by the immune system, sort of trains up the immune system. And then the mRNA disintegrates. And so it doesn't stay in you forever or anything like that. So I think that may be reassuring to some folks. It doesn't get into the DNA, that's different. It just gets into a part of the cell, and it sort of is like a little factory, does its thing for a while, and then is done.
I have a question from a parent who has two children who have both received their first dose and did have some mild side effects, and wondering if they should expect with the second shot them having similar side effects or worse side effects.
In the Pfizer study that I showed the slides with side effects, it looked like they did not have worse side effects after the second dose. So, I mean, that's among the kids in that study. And of course, everybody's an individual, so they might, but we would not anticipate that on average.
A really good, just general public health question for you, Dr. Kelly. What general advice would you give to families looking to protect their health as the holidays approach? Any lifestyle measures that you're saying that are particularly important?
Well, vaccine is the number one, far and away. As you get as many vaccine, you want to protect your 4-year-old, get your 5-year-old vaccinated. Vaccinate all around the most vulnerable people. Anybody who is eligible for a vaccine, get vaccinated. And I'm going to put in a plug for flu vaccine here as well, because if you are debilitated because you got influenza, you are more vulnerable to pick up other respiratory viruses. And it is possible to get COVID and flu at the same time, and that would be a bad deal. So get your flu vaccine, get your COVID vaccine, but I know you're asking about what else can we do? We're often blessed in South Carolina with warm weather. So if you have a gathering with non-household members on Thanksgiving, if you can do it at all outdoors rather than indoors, that really would be much safer. Even if people are vaccinated, you never know who in your group might be immunocompromised and not talking about it. HIV is an immunocompromised condition. People don't want to talk about their lupus or psoriasis, that they're on some unusual medications. So, my advice would be vaccinate, vaccinate, vaccinate. Wearing masks indoors, except when you're eating. and try and eat outdoors if at all possible.
Thank you for that. I'm going to run through, see if I can find any ones that have not been answered. Can you, I think you both talked about this a little bit, but can you speak kind of generally about the data that we're seeing on deaths and what percentage are vaccinated versus unvaccinated?
Yeah, I see a question in the chat box, and it's very good. When you're questioning, how can I say breakthrough cases are rare? There are a couple of different ways of doing this. South Carolina is publishing this data in different ways, and I think that's confusing for a lot of people. When I say it's less than 1%, here's where I get that number. There have been over 2 million people, I think we're up to 2.3 million people in South Carolina who are fully vaccinated. We have had a little more than 10,000 breakthrough cases among those people who are fully vaccinated. And so arithmetically, that works out to be less than 0.1%. I know that South Carolina also has been publishing monthly data on breakthrough cases, but the way we are doing it is when we get, how do we get information about that there's a case? Every physician in South Carolina, every healthcare provider who has a case of COVID-19, they're required by law to report them to us. We also get automatically through an electronic transmission any laboratory data. So we'll hear about any positive tests, except for the ones that might be done as an at-home test. If it's done in a lab, we get that information. We then call those people to follow up, to do contact tracing, to figure out, who else do we need to contact to talk about quarantine. One of the questions that is asked when we do that is, were you vaccinated? Were you fully vaccinated? Number one, sometimes people don't answer the phone at all, and we cannot contact them. Number two, sometimes people say they're fully vaccinated when they weren't. We have two separate databases that do not communicate with one another. So we don't know. We could figure it out, but it would be very labor intensive. We don't know if a positive test is in a person who is fully vaccinated or not, unless they tell us. So it is biased, meaning that we get more people reporting that they are fully vaccinated than people saying, no, I'm not, or people who say, I don't want to answer that question. So that's why it appears that we have such a high percentage of breakthrough cases. And just to finish that conversation, about the average age of our breakthrough cases who are hospitalized is age 70. The average age of cases who have died, because there have been some cases who were fully vaccinated who then died, their average age is 80, and many of them are immunocompromised. So vaccine was never going to work well for them.
Another one for you, Dr. Kelly, and we get this one at the department a lot. How does DHEC make its decisions on which immunizations and vaccinations are required for school attendance? And I don't know if you care to speculate as to a requirement for COVID-19 vaccine, but I'm sure that's a follow-up to this question.
I don't think at this time that DHEC is going to suggest mandate for vaccine as a school requirement. And the answer to how are decisions made, that's a longer, more complicated group decision among a number of different entities, including data from CDC, advice from American Academy of Pediatrics, and many other entities.
Thank you for that. I'm not sure if anyone else is seeing any new ones come in.
I see a couple of questions about, it's widely estimated and accepted that 40% of kids have had COVID. That is the national Sero survey indicates about 40%. And the comment here is that's a good case for natural immunity, especially considering kids are low risk. Yes, but, and that but is a big but. Because we do have reinfections, and reinfections can be severe. What we do know from adults and adolescents is getting vaccinated after you've had an initial infection cuts your risk in half of reinfection. whereas the risk for kids for myocarditis or for allergic reaction is even lower than that risk of severe disease. I also see a question here about, can an adult get a booster if they're going to travel abroad, but they're not in the list of categories? You may have seen in the news that Pfizer and Moderna are both appealing to CDC and to FDA to approve boosters for everyone. But right now in South Carolina, if you want to get your booster, you can get a booster. You do not need to provide evidence that you're immunocompromised or evidence that you have diabetes or some other condition. You can just make an appointment and get a booster.
Thank you. We had a question come in through Q&A about a child with a past history of seizures and whether or not there's any concern about taking the COVID-19 vaccine.
Maybe I should let the pediatrician weigh in on this one.
So my thought with that is that it's probably more important. A lot of times any fever or illness lowers our threshold for seizures clinically. And so, my recommendation, again, is always to talk to your child's doctor. But in general, it's best to vaccinate. We really recommend flu vaccine in that population, again, in order to avoid that spiking fever and, triggering sometimes long seizures. So I would recommend vaccination, but talk to your doctor.
And I see,
thank you.
Well, I see another question about, but severe reinfection in kids is extremely low, and I cannot disagree with that. I think everything in life is a risk-benefit ratio. I know how I would make this decision if I had a 5 to 11-year-old. I think this is your decision as well. This is a choice. I just do want to make the point that when we talk about choice, if someone is in the wait and see group, they're afraid to choose the vaccine, you're still making a choice. You're making a choice to not to choose this protection against COVID-19. So, severe reinfection is extremely low in kids. That's true. I always worry about the unknowns in the future. Where did Delta come from? We were having fewer than 100 cases a day in South Carolina in June, and then bam, Delta just hit us like a sledgehammer. We were having more than 5,000 cases a day. So I do worry about what might happen in the future. When we have a low number of people fully vaccinated, that's opportunity. That's opportunity for virus to continue to circulate, recombine, mutate further. You would get a new variant. So I'm looking at it from a public health point of view. Of course, as parents, you're looking at your individual child's point of view, but I would urge you to talk with your pediatrician.
Personal story too. I have an uncle who died after he got the virus from his unvaccinated grandchild who, was not of the age to get vaccinated. But again, the more folks that can be vaccinated and can protect those around them, the better. It's not just about your child. And then I guess the other comment I see is about death rates in children, and they are low, which is wonderful. However, to have any death in children is extremely rare. And to see, 700 from one virus across the United States is just, it's a huge number to us as pediatricians. That's not something we usually see with any other virus. But in addition to that, we see morbidity, illness, the long haulers type symptoms, other strange symptoms, loss of caregivers. Those are huge effects from this virus. And I think to just look at death is a little bit short-sighted.
Got one more question, and then we'll try to wrap things up. Question as to whether or not you can get the flu vaccine and the COVID-19 vaccine at the same time.
Yes.
Yes.
I did.
Put them in different arms.
Mm-hmm.
But in different arms. Good, great advice. I want to thank you both for being with us. Maybe if you both want to just provide a short closing remark. And Tom, I don't know if you have any last words of wisdom you want to share, but I want to thank everyone that joined us either via WebEx or on Facebook for taking some time being with us for a little over an hour now and answering some questions, and we'll make this recording available for those that want to go back and revisit things or those that were unavailable to join us. But maybe Dr. Edwards and then Dr. Kelly and then Tom, if you have any closing remarks.
I just want to thank you for hosting this and thank you for your partnership. It's really been a wonderful thing to get to know South Carolina Department of Ed better and to work on this together. As far as parents, I understand the worry. That's what we do as parents. We're paid nothing for it and we do it so well. But when you're thinking about vaccinating your child, you need to not, think about your child, but to keep your child safe, you need to keep family members safe. And to keep family members safe, we need to look at our community, and it goes the other way as well. So it's really thinking about a bigger picture. And if you have questions, please ask your pediatrician or your family medicine doctor, your primary care doctor, and get good information. And thank you so much for listening tonight.
And I would say the same thing about thank you so much for inviting me. It's so important to get the word out. Thank you for everyone who has participated. I know there are a number of questions in the chat box still about death rates. Isn't it higher for flu than in COVID? And yes, that is true, but I don't understand that argument. I think we have vaccine preventable diseases. Let's vaccinate both of them. And in terms of the question about how many kids who died were, quote, healthy kids, I would remind you that, the statistics I gave, more than 30% of the children who ended up in the intensive care unit had no comorbid conditions. They were healthy kids. This is not all about death. It's also about severe debility. After you've been on a ventilator for a few weeks, it's going to be a long time for that child to recover. Part of the reason I wanted to make slides was so that I could give you links to papers, so you could look at those charts. When you look for information, don't just look to social media, even though we're doing this on social media, but I mean, seriously, look for the baseline facts, not just the headlines. Try and get the information for yourself.
And Dr. Kelly, to your point, we can also post those slides if you would like, along with the recording, so they can have access to them.
That would be wonderful. Thank you.
Tom, do you want to close us out?
Sure. Thank you, Ryan, Dr. Kelly, Dr. Edwards. Thank you for sharing your information this evening, and certainly thank you to everyone who participated, whether it was on social media or here on the WebEx platform. Information is key, and we as parents, I'm a parent, my children are older now, but parents, we want to have all the information we possibly can when we make very important decisions about the health and well-being of our children. So we appreciate your energy, and we appreciate you being with us this evening to pose these questions and to hear this information. And we just hope that everyone stays well and has a good holiday coming up next week. Thank you, Ryan.
Thank you, Tom, and thank you everyone for joining us. And hope everyone has a good evening, and as Tom said, a safe and healthy holiday season.
Thank you.